You are on call, and the ITU team has called you to review a patient. That patient is a uncontrolled diabetic 63-year-old female presented 2 days back, found lying unconscious on the floor. On evaluation, she had high swinging temperature, so the ambulance crew brought her to the hospital, stabilized in the A&E, and admitted to ITU. The ITU is trying to find what may be the possible reason for her infection, and they've sent the bloods for culture and catheterized, and patient is now stable. The investigation of CT, thorax, abdomen, and pelvis has shown right side kidney being quite swollen, and there are signs of air pockets inside the kidney. So they've called you for your view. How are you going to approach her?
So from the details provided, and given this patient is a poorly controlled diabetic, I'm concerned she has emphysematous pyelonephritis causing her sepsis, which needs urgent intervention. So I'll go and assess her immediately in ITU. On arrival, I will check her hemodynamic stability, adopting CRISP algorithm. I'll take a focus history from the patient. Can I just confirm if she's fully conscious as well?
Yeah, she's conscious, she's responding to commands.
Okay, so I'll take a focus history to ask about the presence of any loin pain, any preceding urinary tract and lower UTI. I'll ask her about associated fever, rigors, vomiting, or visible hematuria. I'll confirm her past medical and surgical history, including any previous urological history or intervention. I'll determine if she's on any anticoagulant or antiplatelet medications. And I'll then go on to perform a chaperone physical examination. I'll note her basic observations. I'll look to elicit any abdominal or loin tenderness or palpable masses. And I'll also check her fluid output, urine output from the catheter, and I'll also review the rest of her investigations, including her urine cultures, blood tests, and I'll also look at the CT scan images myself.
Okay. Examination wise, she is otherwise stable now, and the IT team has done a good job in stabilizing her from the cardiopulmonary status. The CT scan did show that the right kidney is twice the size of the left kidney. No signs of any stones found, but unfortunately, she has got air pockets and quite a heterogeneous look of the collecting system.
So this patient, the CT findings are in keeping with an emphysematous pyelonephritis. I'll explain in term. Do you say that there are any gas pockets as well, fluid collections?
Yes.
Okay. So in terms of the type of emphysematous pyelonephritis, this is leaning more towards a type 2 with fluid pockets, but it still requires urgent intervention. So I'll explain the diagnosis to the patient, that she has a severe infection of her kidney causing her to become septic, and I'll counsel her about undergoing drainage of the kidney, and my initial choice recommendation would be for her to undergo a right percutaneous nephrostomy insertion.
Okay. We are discussing this picture with the radiologist. The radiologist found that the whole kidney is replaced with like a soft tissue like gluey heterogeneous material. They have tried to keep nephrostomy, but the nephrostomy haven't drained anything. Her ureters are quite collapsed, and the whole pelvic system seems to be quite mucky material, and nephrostomy was not much useful. Unfortunately, blood-wise, her CRP is quite high. Started with 800, and the repeat CRP in 48 hours was 900. She is having high swinging temperature, requiring cardiopulmonary support, but not intubated. What is your next steps?
My next step would be to consider further interventional management, given that the nephrostomy tube has not appears to have not drained the kidney satisfactorily. I will speak with the radiologist because one option could be to increase the size of the nephrostomy tube. However, I will also consider placement of a right ureteric stent to provide maximal drainage to the kidney. And again, I'll given per sepsis and risk for general anaesthetic, this would be better achieved in an antegrade approach under local anaesthetic.
Okay, the radiologist tried to do what about the antegrade stenting placement, but the PUJ is not possible by any guide wire. They try to liquefy the mucky material in the pelvis by injecting some normal saline and aspiration. Only the saline which is injected was withdrawn. There is no way that mucky material is getting dissolved, and she is quite symptomatic, and her pain and discomfort is gradually increasing. The anesthetists were not very happy for her to take for stenting. They feel that stenting alone, if you are planning, that itself can cause morbidity, so including mortality. So what other steps you have?
The other steps would be in terms of definitive management, and if drainage has not succeeded, then I would discuss this with a more senior colleague or at a MDT, but it would be the more senior colleague in a more timely fashion. The next step in management would be to consider an emergency right nephrectomy to achieve source control. But this in itself would be associated with a high morbidity and high mortality, and requires careful discussion with ITU, anaesthetics, the patient, and their family.
Okay. And what factors you will discuss with the patient and the family before taking her to theatre?
So I will carefully counsel them about the rationale for surgery in removing the source of sepsis, given the previous failed measures, and to improve her and save her life. I'll explain that the alternative treatment of continued antibiotic management or further attempts at stental drainage would likely induce making a condition worse. I'll explain the risks of the procedure, which are quite significant, including a higher risk of bleeding, of stirring up further sepsis, of injury to vasculature, bowel, or her liver, needing major surgery and causing life-threatening complications, and also that there is a risk of on-table death or even post-operative death despite a successful operation.
Okay. Patient and especially the patient's relatives are quite concerned, but they understand the situation where if you are not taking the patient for appropriate nephrectomy, that will also result in death. So they are agreeing and signing the consent form. What are you going to do on the day of the procedure you are planning?
So on the day of the procedure, I'll confirm the consent with the patient, ensure that she is marked, and that I review all of the preoperative imaging. I will ensure that I have other colleagues available in the theatre, including a more senior colleague in urology, vascular surgery and general surgery because of the high risk of complications, and that she has an ITU bed to go back to. I'll ensure in theatre that WHO checklist was performed with the patient prepped, consented, marked and anaesthetised, to include VT and antibiotic prophylaxis. I'll place the patient into supine position, prep and drape the area, and my incision of choice would be a midline laparotomy going from the xephisternum to the pubic symphysis. I would retract the bowel and enter the retroperitoneum, incising over the aorta, and I would perform a very careful dissection with the aid of my colleagues to mobilize the kidney, isolate the high structures, clamp them, and to perform a vigorous washout as well.
Okay. What difficulties you may be expecting? What instructions you will inform your theatre staff to keep things ready?
So I will instruct them to have the appropriate equipment on standby in terms of a laparotomy tray and also a vascular set. and also to ensure that resuscitation equipment is in close proximity as well, in case the patient does go into an on-table cardiac arrest.
So you want to plan a laparoscopic nephrectomy if feasible?
No. So my choice, given how
Go ahead.
Given how unstable she is, and given if laparoscopic nephrectomy were to be performed, a surgeon with appropriate experience would be required, but this is a rarely performed approach in the emergency setting, and if any complications were to occur, then an open access would need to be, there is a high risk conversion to open anyway with this particular case.
Okay, good. Well done. I will give my feedback. Number one, trying to place retrograde stenting, you need to be a little bit careful, because from the way by which the examiner presenting the CRP and presentation, you should get a clue that, okay, this is a scenario where they are going to discuss the emergency simple nephrectomy. Okay,
Yeah.
That clue may happen already, but you want to go slow, and you don't want to take the patient directly to the nephrectomy. You want to do some pre-nephrectomy steps also. I agree with that, but you should be quite strong that this discussion is simple emergency nephrectomy, and I should prepare your back of our mind as two things. The one is the active mind, which always talks and answers to the questions, and there is a passive mind which prepares for the next question. And a good candidate can make sure that you're dragging the examiner to the areas which you're confident of, which also we've seen in the few sessions before. So I will not plan for a stenting, because number one, the stenting is a very temporary procedure. The radiologists have clearly reached the pelvic axial system comfortably, but the material is so purulent and mucky, and it's not possible to be drained or aspirated by a 6 French or 8 French nephrostomy tube. So in this situation, stenting may not add much. That's number one. Yeah. Number two, again, even for stenting, you need to mobilize the ITU team, you need to book an emergency CPOT theater list, and so many things have to be done. It's better to consider the nephrectomy in the same sitting, because there is no point in preparing just for stenting and then attempting a stent getting coiled in the mid-ureter or just upper ureter and not able to drain, and then stop the procedure, wake the patient, after 24 hours discuss the nephrectomy. So you should be prepared for everything under the sun in one sitting itself if you are doing under GA. That is the other one. I'm happy with your way by which you are preparing, keeping the ITU team, cardiopulmonary team, everything in place. During the laparotomy, when I asked what other things you will keep ready, my aim is something like if you think the CT shows any involvement of like hepatic fracture of the large bowel, you may need a hand from colorectal surgeon or somebody who is doing the major laparotomies regularly. You did introduce your colleagues in the early evaluation stage, but later on the surgical date also, you can say that I will keep a senior consultant colleague on my side, or another registrars also. We need more hands, more the merrier. And suddenly you said you will keep a laparotomy set and emergency tray for cardiopulmonary resuscitation ready. That's why I got a little bit deviated to say, so if you're keeping a laparotomy tray, means what are you using now? You're using itself is laparotomy tray, isn't it? So that's why I thought, okay, is there any role for lap? And you correctly said there is no role for lap. In these kind of situations, emergency nephrectomies, if somebody asks you any role for lap or robotic, you can directly say there is no role for laparoscopy and robotic. We just want the procedure to be a quick in and out as much as possible. Chances of open conversion is so high, tissue plane won't be well defined, so I will not plan laparoscopy for these scenarios. That's absolutely fine answer. Okay. Yeah, no other things.